Welcome to the Food Junkies podcast. Here, we aim to provide you with the experience, strength, and hope of professionals actively working on the front lines in the field of food addiction. The purpose of our show is to educate you, the listener, and increase overall awareness about food addiction as a disease with abstinence as the solution. Here, we talk about all things recovery. Most importantly, how to thrive rather than just survive. So stay positive, make a change for yourself, tell others about your change, and hopefully the message will spread. Hey Food Junkies listeners, Clarissa here, and today we have a great episode for you. In my private professional practice, I work with numerous clients who have ADHD or other forms of neurodivergence. I also have a personal history with neurodivergence, having likely had ADHD from a young age and later sustaining a traumatic brain injury in a car accident at 25 years old. Neurodivergence can explain many aspects of an individual's experience, but it can also complicate our recovery because it can present additional challenges. Today, we are going to interview Claire, who's going to delve deeply into the topic of neurodivergence and eating, highlighting the unique considerations for those on the spectrum and provide valuable insights into how to effectively address some of these issues. Claire Sehinson is an educator researcher with a functional medicine and nutritional therapy clinical practice. She brings to her work her passion and lived experience of being multiply neurodivergent and diagnosed with autism, dyslexia, and ADHD as an adult, whilst navigating her own recovery from multiple mental health issues throughout her lifetime. Claire has over a decade of specialist clinical experience working with complex illness, trauma, fibromyalgia, and chronic infections. Claire is the head of research at the Optimum Health Clinic, an integrative body-mind clinic, where she researches and trains practitioners on cutting-edge protocols to support complexly ill clients. We are so excited about this episode, and we hope you enjoy it too.
Well, welcome so much, Claire. We are so excited to get to talk to you. This topic is very important and personal to us on so many levels. And so we were wondering, just to kind of start us off, would you be willing to share your personal story with neurodiversity and your why as to why you decided to pursue this career professionally?
Okay, it's quite a long story, long convoluted story. So I was late diagnosed autistic, ADHD and dyslexic. So that triple kind of late onset diagnosis where it wasn't picked up in childhood, in my formative years, but instead I accumulated a whole bunch of other chronic illness diagnoses instead and mental health. I think the last time I counted it was in the double figures. So it was things like chronic fatigue, fibromyalgia, lots of mental health issues around and eating disorders. So to disclose binge eating disorder and ARFID, which we'll probably touch upon later when we delve into, the mechanisms a little bit more. But yeah, things like OCD, Tourette's. So I had a lot going on. And I think a lot of that overshadowed the autistic traits and the ADHD traits, which we'll look into a little bit. But I started my training in conventional medicine. I think my brain style was just incompatible with that environment. So it's a really overly sensory, overwhelming environment, lots of changes to your schedule, the rotas that you're on, you're suddenly working overnight and then you're back to a daytime schedule. So I really, really struggled in that environment, dropped out of that, and then eventually retrained in functional medicine and the more naturopathic route and nutritional therapy. So it definitely answered a lot of questions about complex clients, because I've always been quite interested in unraveling complex cases, I think because I was one. So I just, no one really understood my symptoms. I was kind of fobbed off quite a lot and gaslit. A lot of my symptoms that I was trying to describe, doctors would go, oh, that's not really a thing, or, oh, that's weird. So I'd go off and have to do, piece together my own research, and functional medicine kind of offered me those answers. But even within that framework, I had a lot of clients that I got better. And I would sometimes be a bit jealous because I would plateau, my own illness would plateau and my own eating disorder tendencies would flare up. And I thought something's missing. And it wasn't until I discovered my own neurodivergence and that a lot of the frameworks and treatment protocols, even within my functional training and nutritional therapy, they just weren't really fit for purpose with how my brain worked and how I was processing things and my behaviours and how I was interacting with food. So it just sparked a lot of unlearning everything I learned. And then just having a bit of a crisis, like, what am I even doing with these people? And is it harmful was the first question, I asked myself. And then just through that, working through those issues and then working with clients and figuring out what was more affirming to neurodivergent people, I kind of got into this career, which is a bit more specialized. I love educating because of my, the autism and ADHD. I get very overwhelmed, a lot of empathy fatigue. So I have to keep my caseload quite small now, but I love to know everything about those people. So they space a certain amount of them. But I do a lot of education, a lot of training, lecturing and conferences around that to train practitioners. And I've got my kind of tiny little Instagram info site that I like to put information on there for patients, because not everyone has access to this kind of integrative care, or, if we can just make people aware of, some of the unique differences, and then they can take that to their doctor and have that conversation, then it, hopefully will help more people. Kind of the career chose me, basically, is the short answer.
Right. It's just, I can hear your passion so much in what you speak about. And I can relate so much to what you're saying in terms of like getting to this one place where you're feeling pretty good. And then it's like, why are these symptoms coming back again? Like, I thought I had pieces figured out, but there's still always like, we're finding more puzzle pieces to a kind of our own recovery journey. So I'm wondering if you can speak about some of the myths that you've heard about what people think ADHD is, and then also what are some true real challenges that people face when they do have ADHD?
Yeah, so I think I was thinking about this, and a couple of the myths, the biggest myths are actually the name of the condition. So the first is ADHD being a disorder that needs to be fixed. And I guess it's a diagnostic criteria that's a very deficit-based diagnosis. You're not diagnosed based on all your strengths, as that would complete this kind of better rounded picture of what ADHD is. But it's effectively someone with ADHD under distress. It's a stressful trait coming out, and all of the struggles that they have in just following the rules of society and how it's set up. So to me, they're not really symptoms of disorder or disease. They're just signs of someone in distress and someone whose brain mismatches their environment. It is positioned as a neurodevelopmental disorder, which means that it's very pathologized, and a lot of research papers, when you look at you really delve into the statistics and everything and how it's written, it's very pathologizing, and they're looking to fix the condition rather than support it and accommodate it. And what it actually is, it's just a difference in the way our brain develops. So it's a neurodevelopmental difference. And that just deviates from the way the neuronormative or the typical. So because it's so at odds with how society is set up, a lot of the traits have become stigmatized. So the stereotype that people think of this inattentive person that talks a lot, can't sit still, fidgets, is distracted, always late, impulsive. That's the kind of stereotype that I had in mind. And because it's so deficit-based, I didn't see myself in that. I just thought, no, I'm a really good, I pay attention and internalized a lot of those traits. So, but we know there's so much more to ADHD than this. And the second myth is, again, a name. It's the attention deficit part, which isn't really true. So, it doesn't really, it looks like that someone's not really focusing, memory issues, not paying attention. But actually, one of the key traits of ADHD is hyperfocus. So we can become very, very deeply immersed in something that we're interested in, to the point where nothing else registers. So people can be talking to me and calling my name, and I don't hear that. Or I won't hear my own or feel my own hunger signals, toileting needs, all of that stuff, tiredness. I can definitely override tiredness to the point where it's gone past the point I can even get to sleep. And that's what leads to a lot of these feeding issues, a lot of the burnout kind of issues that we have. So it has a huge impact on health overall. And I guess there are some neurobiological differences. Did you want me to delve into that? Or was that a little bit too much of an info dump? So it's typically associated with executive functioning difficulties. So when we think of that, it's kind of all the stuff, the brain function we need to, filter out distraction, to control our impulses, to plan and achieve our tasks. and to largely override the limbic system, which is, the part of our nervous system that's associated with emotions and rewards and kind of, memory and fear, that part. But our brain is slightly delayed, 2 to 4 years, but even a neurotypical brain isn't fully mature till about 35. So I think that's a lot longer than people expect. We kind of hear in medical school, oh, it's 25. It's actually, to complete that prefrontal cortex myelination, it is 35. So a lot of people, my clients, their brains are actually still developing. And, it's quite funny to think of that because we don't have the rational sort of coping strategies to make a lot of these decisions. So in ADHD, it's a little bit more pronounced, so 2 to 4 years delayed. And then there's differences in the way our frontal lobe connects to our limbic system. So, we can struggle with sort of sensory filtering, and there's a lot of emotional sensitivity that we tend to act on. One of the biggest traits, which isn't a diagnostic criteria, which I think a lot of people believe it should be, is rejection sensitivity. So I don't know, have you heard of or experienced it? But rejection sensitivity dysphoria is something that almost everyone that I've met with ADHD experiences to a very high level. And it's actually just extreme discomfort or even physical pain at even the perception of rejection. So it's this sensitivity to criticism. And you can kind of see why that would feed into things like body image. Because if someone makes an offhand comment about food you're eating, you could take that as a personal criticism. And we just have a sensitivity to that because we're very emotionally or limbic system driven people. So when you don't have the rational, kind of executive functioning overriding that, you can kind of make a lot of decisions and that stem off from limbic system driven. So we're kind of navigating the world through that. And a framework that I really like, which kind of highlights why we like to focus on certain things and not others, is William Dodson's interest-based nervous system framework. So he's written a fantastic paper on that. But it's effectively, we will focus or be motivated by things that are interesting to us. So there's 4 components of that, rather than what's important. So obviously priority in the regular world will be certain things, but my brain will completely just want to go off and research and sit in some sort of research rabbit hole with another topic that I find interesting. So the 4 things tend to be things like novelty. So I'm the type of person, my friends used to call it all the gear and no idea. So, for example, I decided I just wanted to get into woodworking one day. And then I bought within a week a circular saw and a nail hammer gun and all the stuff. And they were like, what are you going to do with this? No idea. So no idea how to use it, but I bought all the stuff. So we're kind of the novelty of it all and the collecting things and then getting all the stuff that you need. So a bit of a shocking problem, but we like also new environments, new food, new people. So it can look like novelty seeking and it's kind of chasing that temporary dopamine hit that can be quite low in ADHDers. And the other one's urgency. So I'm the sort of person that will leave things to the last minute. And it's not because I'm disorganized, well, sometimes it is because I'm disorganized, but I just operate much better under pressure or under that kind of in that high pressure cooker environment. So working in A&E, for example, or you guys would call it ER, that's optimum kind of pressure that my brain functions really well in. So I make really good decisions. I have mental clarity in that moment. But if you just give me all the time in the world, like working in dermatology or something that's a bit more relaxed, I just have no interest at all. So that doesn't pique my interest. There's also obviously interests and passions, because that's where we're engaged with our emotions. So something like art and sports and fitness, I'm really into that sort of thing. So I could spend endless time on that, endless hours just looking at social media, engaging with that. And the final component is challenge or competition. So a lot of people, you'll see a lot of competitive athletes or kind of people in high pressure competitive roles. That's, again, another optimum state that ADHDers tend to thrive in. So you'll see a lot of those traits come up and they're very motivating for that person. So that tends to be where our attention, our motivation goes. And I think that's a really nice, non-pathologizing way to think about it. But then when you think of the person that you've now got to work with, who's motivated by that, and then they've got to function in society, which is completely the opposite of that at times, we can struggle a lot. So
I was just going to say, it makes me think about, so obviously there is crossover between trauma and ADHD, right? Like there's crossover of symptoms between trauma and ADHD, not to mention the fact that, the clients that we work with substance use disorder, eating disorders, all of that. I think for me, it's so interesting because here we have, whether it's the diagnostics, statistical manual that we use to diagnose or the ICD, whatever it is we're using to diagnose, sometimes I get really disheartened or sad that we are putting these diagnoses on people when really it's just they have brains, or I have a brain, or you have a brain, right? We just have brains that are different from other people, and the world is set up for the majority maybe, and we're the minority. Like, I'm not really sure how that goes, but like you kind of described it in the beginning that, we have to figure out different ways to cope in this world that's not set up for what we've got going on upstairs kind of deal. Yeah.
Yeah. I mean, it's quite funny. Another neurodivergent friend and I, who's a therapist, we were kind of saying, imagine just a neurotypical person was in the DSM. What would that look like? It's like they lie, they're grumpy, compulsive, ambiguous and vague. You just kind of have all these symptoms. Imagine we just characterize people by their deficits. It just doesn't give you a well-rounded idea of that person, or how to, when you're trying to fix those traits and make them, more neurotypical, it just encourages masking. So it's not actually helping them get better. It's just making them change their behaviors to please you. And with a lot of, there's a few studies that look at things like behavioral therapies in autistic children, and kind of later on down the line, it leads to increased rates of suicidality and self-harm. So it does have an impact. Getting the label right, it can be so helpful for some. For me, getting that autistic diagnosis and my ADHD diagnosis, it was, life-changing. But then, it's kind of what happens after that. There's so many routes we could have gone down, but it's about how you adapt your identity. There's so much kind of to unpack because there's so much trauma that overlaps with it. So yeah, it's a really complex field.
Yes, totally. And I feel like it can't be boiled down, like you were saying, to this one box, this set of criteria that are, not strength-based, to try to identify. Yes, it's a double-edged sword. Yes, it's so nice to finally get that correct terminology to describe what you're experiencing. And if it shows up in a way that then, like you said, so there are interventions that have been, I guess, put upon people to make them closer to or fix them, quote unquote, fix them in some way. And it actually ends up being harmful in the end. And so it is really important that we have this conversation today. So again, I just want to say thank you for being here.
Oh, no, you're welcome. I was very excited about it.
Yeah. So I'm wondering, when we have brains that maybe are neurodivergent, whether it be ADHD, because that's maybe where your specialty lies, amongst other, I guess, manifestations of that, how does the brain deal with glucose and sugar differently than somebody with maybe, say, a neurotypical brain?
Well, there's nothing technically metabolically different as how sugar is processed, but sugar is addictive, and even the pursuit of sugar, we start to increase dopamine levels. So that's something that's been found to be low in people with ADHD. With blood sugar kind of ups and downs, so if we're kind of on this roller coaster, we're not eating and then we're eating a ton of sugar and our blood sugars just kind of go up, down. People will they'll tend to experience more fluctuations in their symptoms and their energy and their mood when their blood sugar's on this roller coaster. And ADHD rarely travels alone, so there's lots of co-occurring health conditions. I don't know if you found in your clients, they'll usually have several mental health issues attached to that, often physical health too, things like IBS, food intolerances, fatigue, burnout, adrenal kind of stuff going on. So sugar can massively impact all of those things. And the whole picture means that they're symptoms associated with ADHD will get a lot worse. And also when we're hyper-focused, we tend to tune out these subtle internal signs of being, kind of hungry, or that our blood sugars are going up and down. So we usually figure it out when we're totally famished and we just, we'll eat the first piece of sugar that we can see. So it can lead to then binge eating behaviours and impulsivity around food. And it tends to lead to more unhealthy food choices. So it is a vicious cycle. And it's something I see with almost everyone with ADHD. There's a kind of very strange relationship with the food. There's no one's got a kind of perfect eating on schedule. There's usually blood sugar issues, and it can be quite a quick win. So it can sound boring. A lot of my patients roll their eyes. And then we'll use things like a continuous glucose monitor. I don't know if you've come across those, but people it's becoming a bit trendy at the moment, but it's a good way for people who don't have that innate connection with what's going on in their bodies. And it could be something like a neurodivergent issue, or also with trauma. A lot of people are disassociated, and you don't want to just suddenly get them to feel all their feelings, and they find it quite difficult to check in and really tap in. So sometimes having something external that they're reading off a monitor is actually a bit more trauma-informed and a bit safer to work with, and then you can kind of focus on that. And ADHD love a gadget, so for about 2 weeks, they'll be really diligent. But it's kind of enough to see that relationship with, mood and energy, and it could be IBS symptoms. So it's not necessarily just the ADHD symptoms that we look at. So.
Yeah. And I think when we're speaking about what we typically see with individuals with food addiction, it would definitely lean more towards the binge eating disorder and or bulimia. Those would be the more predominant eating disorder symptoms or eating disorders that then potentially can start, but then may progress into the food addiction or fit on the spectrum. Both of them kind of fit on the spectrum. And I'm wondering if you could speak to how ADHD can kind of exacerbate those two eating disorders specifically, also touching, then we'll kind of dive into the interoception, which is so key.
Yeah, absolutely. So it's quite well established now in the research that ADHD increases the risk of eating disorders. I think it's 3 times more likely to have a diagnosis of an eating disorder. And the other paper I saw recently was adults with ADHD were 5 times more likely to have some sort of restrictive behaviour. So it's a bit more of a controlling behaviour around food and their weight. So it could be restricting food or weight loss pills or fears around gaining weight. So it's definitely a well-established kind of relationship. The most common is binge eating disorder, I think, statistic, and then bulimia nervosa. And I think the third might be anorexia nervosa, but the non-typical type. So there's lots of different variations. When I speak to my clients, a lot of them have a mixture. So I think in the DSM, there's another acronym, which I can't keep on top of because they all sound so similar, but a lot of them don't fit exactly into the diagnostic criteria. I think that's where it's quite interesting, because I did a post recently on Instagram, and it was the overlap between neurodivergent traits and eating disorders, because some of them could just be neurodivergent traits playing out that looked like diagnostic criteria for eating disorders. And then you can get a misdiagnosis and then that treatment be harmful. So there's I've had a few clients, kind of where we've been working through exactly this. They've been in the system for such a long time, quite medically gaslit, and they did have an eating disorder of sorts, but it wasn't the one that they were treated for. And then that resulted in a lot of trauma. So there's that whole, we need to kind of really observe, and someone might not fit neatly into those categories. But yeah, I think some of the underlying triggers for those behaviours could be things like rejection sensitivity, dysphoria, and body image issues. That's quite a common one that I'll unpack with my clients. There's an interesting one with stimming. So stimming is self-stimulatory behaviour. It's a way that neurodivergent people regulate their emotions. So it could be repetitive movements, talking out loud, talking to yourself, singing to yourself, just anything repetitive. But oral stimming is something that a lot of people with ADHD and binge eating, or primarily binge eating disorder, will use to alter their state. So it could be some people just like chewing or making popping sounds with their mouth. Other people actually need to use sort of sensory input. So they'll have an association with a comfort food. And that's where the word comfort food probably comes from. But it'll be crunchy foods, or it'll be a specific type of food from their childhood. And they'll use that as sensory stimulation or emotional regulation. So with that, you kind of don't want to take away their only thing that regulates them in that moment and go, why don't you swap a carrot? It's not going to do, it's not actually going to hit the spot or do the job. So that's kind of something that I see a lot of. And it's then having that conversation, and there's a bit of acceptance around it when I work with it. It's just like, that's your thing. That's the one thing you love. I promise you I won't take it away from you, and we'll work on other ways, because there's so many other ways to work with the condition. But that's a really big one that I see with binge eating. For some people, it is grounding, so they cannot sleep. And I used to do this myself, but I would not be able to sleep unless I ate a ton of carbs. And they would have to be the cheapest carbs you could possibly find, nothing like whole grain rye bread. It would be just, white bread with butter. And that would guaranteed get me to sleep. It just had this sense of fullness that I associated with sleepiness. And it was another way to get me to sleep. Otherwise, I just wouldn't. So a lot of these things are coping strategies. And you could say that is disordered eating. Therefore, we want to fix it. But then you're like, what is the alternative? So it's just a really complicated conversation that becomes, right, when do I want to do it? If I do that behavior, is it disordered if I just do it as a one-off? Or if it's now becoming dysfunctional and impacting my life, then I perhaps don't want to. So it becomes a choice rather than you need to change this or else you can't leave this vicinity, or, that sort of thing. So yeah, it's quite complicated when just those two things, when you think about it.
It's so complicated. And as you were sharing, it made me think, it just revalidates why I am a harm reduction clinician and have been for almost 2 decades. Because one, I want to go low and slow, right? Like as low and as slow as I can with intervention, because it's so, first and foremost, folks, that for any of you listening, Clarissa and I can see the same client presenting the same symptoms, and we can diagnose 2 different things, right? That unfortunately, that is how it works in the world with the DSM and the ICD and all of that. So I always want to try to go in as low and as slow as possible, because I don't want to cause that harm, and to the best of my ability. And I know that I'm going to make mistakes because I'm still just a human. But if it's client led, right? If I'm listening to the client and I'm helping them to tune into their body signals, their own messaging, what works for them, whatever, chances are we're going to do a lot less harm. And then if I just decide, well, this is straight addiction and you just need to get rid of that comfort food and the crunchy, whatever it might be. So that really, I just thank you so much for sharing that and just like helping me to remember, like, I'm not doing anything wrong, practicing in the way that I practice with clients. The second thing that you said that just really like nailed it for me is, again, we are norming, quote unquote, norming these behaviors, these, I don't even know what we want to say, like symptoms. I mean, we're calling them symptoms, but they're just expressions of the limbic system, that nervous system that's dysregulated, whatever it might be. We're norming, quote unquote, norming it against a neurotypical individual. And we're saying the neurodivergent side of it is sick in some way, shape, or form, right? It's in this manual saying this is sick, this is wrong. And we have to get you as close as we can to neurotypical in order for you to be quote unquote well. And that just irritates my inner demons, right? Like, I'm just like, that's so not okay. That's so not okay. And I think like the mama bear, the advocate in me for my client shows up and says, who says, and who are they? And you know what I mean? And so it just brings me full circle back to the more we can know and understand about, individuals who experience the world in a way different than somebody else. And how can we show up and support them to live their best life? To have the mental strength and fortitude that they need to live in the world in a way that makes sense to them. I feel like if we can do that and come back to like, then we're doing our job. I don't know. I mean, maybe that's like a rabbit hole and a soapbox. I don't know, but Claire, you get me going.
No, I love that. And I love that your patients have you as an advocate for them, because I think the danger is with a lot of these frameworks and our healthcare system is we project our expectations of what looks healthy. There's so many words I've taken out of my vocabulary. Working in functional medicine and then eating disorders and diet and nutrition are just a small part of that. There's so many other things like lifestyle, all sorts of things that we work with, but things like cleaning up your diet and you're just like, oh God, what does that even mean? Or you look at the research behind inflammation and it's like the Mediterranean diet that my family would definitely not have eaten. But, it's kind of I think projecting our ideas of neuronormativity, and there's a lot of internalized ableism. So when I started training, I was saying all of this stuff, and I'm just horrified to look back on it. But also, I can retrain, relearn. You either feel uncomfortable with it and can no longer do it, or you just continue to do that and potentially cause harm. And I think we kind of sit in that first camp. So, yeah, but I think it's a very uncomfortable thing. I've had, luckily, all the talks I've done, I had really good engagement, and people are just like, I'm just so ready to listen to this. I think we're at a state now where we're ready for it. I think in the past, it would have been booed off stage and kind of, just seen as too challenging to deal with. So, yeah, I'm so glad that you practice in that way.
Yeah, well, I'm so glad that you do too. And it's so nice, again, like just to know, like, we're not alone in this. Sometimes I start to feel like my neurodivergence, my neurospiciness, it like tells me stories that maybe aren't true, but I think it is. It's just, we live in the world, we exist and experience the world just differently. It's not bad, it's not wrong, it's not broken, it's just different. And sometimes we have to work a little harder to, I guess, fit in the spaces that maybe fitting in makes sense. And I sometimes just don't care. And I say, take it or leave it. Like, what you see is what you get. If you can't handle me, then you don't need to be and no harm, no foul, just saying like, I know I'm not for everybody. And I just encourage others to stand in that truth if that's theirs too, and I just.
Oh, absolutely. I love that.
Yeah, I just appreciate that. Yeah, totally. So when we're talking about all of this, experiencing the world in a different way, can you really speak to us about that interoception? I can never say that word, Clarissa, you're so much better about it. And how that affects us as individuals or anybody, right, with ADHD or any sort of like neurodivergence when it comes to feeding and eating. I mean, you kind of touched on it a bit, like speaking about some of those manifestations of it. And what are some ways that neurodiversity and interoception affect the choices that we're making?
So it's a massive piece. And I think it's been largely ignored up until now. And I think now with the emergence of, our brains are different, therefore our entire nervous system must be processing things differently, it's just coming to light and it's making so much more sense. But it's effectively, interoception is our inner experience. So how we feel our feelings, how we interpret information that's coming into our bodies, either from the outside or the inside. So the outside would be things like exteroception. So if you're thinking of sitting in a restaurant, that sensory experience would be impacting on how you interact with food, your appetite, all sorts of things. And that would be exteroception. Interoceptions inside our bodies. It's made of a few components. So we have sensory receptors throughout our bodies, throughout our gut, in our skin, everywhere. And they send sensory data to our brains, primarily via the vagus nerve, which I'm sure everyone's heard about now, how important it is. But it's mainly information up to the brain. There are different parts of the brain that deal with interoception, but a large part in the research is the insula. And this part of the brain has to receive the information, make sense of it, and kind of figure out what's going on, what you want. So it has to attach a meaning to it. And that meaning then is connected to, do I need to do something about this to maintain comfort or balance? So it could be emotions, so affective stuff like fear, anxiety, safety, boredom, all of those things. It could be homeostatic or physiological. So it could be, I'm hungry, I'm tired, I'm too hot, I'm in pain, I've been sat down too long, I need to move. So all of that information, then the brain has to decide, do I want to do something about it? And then you have some sort of output. So it's like, do I want to run away? Do I need to eat something? Do I need the toilet? Reflex action or urge or behavior will result from that brain interpretation. In neurodivergent people, there's a lot of things that can go wrong with interoception, or that's just different. So we can get mixed signals sometimes, and that's a sensory processing issue. So typically with people, especially autism and ADHD, we can sometimes have a lack of filters, and that's things going in and things coming out. So a lot of us will blurt things out, which I definitely do a lot of the time. So the lack of filtering of what exits my body, but also enters my body. So I will absorb, I think, something like 80% more information than a neurotypical person will. So if you think of, there's so much data that I'm absorbing from my environment and also on the inside of my body, that can easily oversaturate the system. So I think of it like a computer. You're typing loads of information into a computer. It's going to get hot overheat and probably shut down or have some sort of reaction, freeze or whatever. So I think of the neurodivergent nervous system a bit like that sometimes. A lot of this information, it could be information from our food. So, so much, I think of food as data a lot of the time. So I think of, the texture, it's giving you an idea of whether this food's fresh or it's rotten. If you think of evolutionary times, there's different sweetness and, tartness flavors that indicate whether it's poisonous or not. So our guts are highly sensitive. There's a lot of our nervous system in the gut that's detecting whether things are good for us or bad for us or what we need. So a lot of that food information for people with heightened interoception. So this is where let's use the gut because that's a great example of kind of that interaction. They can be picking up on a lot of sensory data from their food. So where we say, oh, you should eat 10 veg a day, which is apparently how much we're supposed to eat, and all the colours of the rainbow, even before a person puts it in their body, it could be overwhelming to their nervous system because it's so much information that they're absorbing. That could be overwhelming. And then that enters the body and you've got to then deal with all these textures and flavors. And sometimes they're mixing together and creating new textures. So you get some people with sensory sensitivities that with heightened interoception where they're quite hypervigilant to a lot of different things going on. And that creates an overwhelm. And it can look like things like unexplained IBS or food intolerances. I do quite a bit of food intolerance testing with people who, maybe can't tolerate wheat or dairy. And a lot of the time people will come with loads of food intolerances or just, I can't deal with this and this food. And you'll test them. It's absolutely fine immunologically. But when you look at, they're getting genuine symptoms like bloating and feeling sick and feeling nauseous, stomach aches, and sometimes it can be heightened interoception. So it's just too complicated. And when you ask them, what do you want to eat? And they'll say beige food, chicken nuggets, chips, like really bland, crispy, no wet food, that sort of thing. So you get the heightened interoception. On the flip side of that, I get a lot of people with muted interoception and they can get no signals from their digestive tract at all. So, they could actually have a lot going on in there. So I've done stool tests and all sorts of things. And it's like, geez, there's a lot going on. Like, how are you not feeling any of this? But they won't get hunger signals. They don't get any kind of cues from the digestive tract. Sometimes until it's too late. So I've also seen an A&E in emergency twisted bowels and things where you kind of think, why did nothing register up until the point where you had a twisted bowel and it's an absolute medical emergency? So, and that's that kind of muted interoception. They just don't get that signaling and the feedback of what's going on in their body. So you've got two ends of the spectrum and they can both be linked to different types of or they both have nutritional impacts, as in, if you've got this heightened interoception, we have ARFID, which it's a newer defined eating disorder. So it's avoidant restrictive food intake disorder. But one of the categories of it is a sensory texture aversion, usually to the characteristics of food. So it could be certain taste, certain texture. But I had this kind of in my teens. It was pre-2013. So wouldn't have been diagnosed, but I would only eat about 5 different foods. And it would happen when I was very, very stressed. So I was going through a period of trying to go to university, massive change from leaving my house, leaving everyone I knew. And it was sudden onset. Almost 1 week I was fine. Next week I could only eat 5 things or I'd get genuine symptoms. So there's that kind of difficulty with sensory issues. And then there's also the kind of trauma fear-based ARFID, where it could be, having GI issues, like digestive issues, having IBS, having inflammatory gut symptoms, witnessing someone choking or choking yourself. And then there's an aversion to a lot of different types of food. So it could be very sensory or fear-based with that kind of condition. But that's a very interoceptive-based eating disorder. So when you're working with that, I think blindly going, right, we're going to start increasing your food repertoire without addressing the fact that there's sensory trauma going on. It's not picky eating, it's sensory preferences, and it's something that the person can control, or without addressing the reason. If you had tonsillitis or you had a major viral infection when you ate those foods, of course you're not going to want to put it back into your body. It's adaptive. So I've seen kind of some practitioners just kind of start the whole schedule, this framework, without really understanding why it's actually benefiting the person in that moment and really talking to them about that. So yeah, we can do a lot of damage with not knowing where the reasoning behind something like that.
No, I think it also makes a lot of sense for the clients we work with. A lot of them struggle with like volume addiction. So like they aren't able to tune into their hunger, but they also can't tune into their fullness. And that may be part of the reason that they over consume to some degree, just because they don't have that level of interoception. And I mean, I can certainly relate to not being able to tune into my own signals. I could go without eating all day as long as I was busy and stimulated and like da da da. And then it's like I have to eat emergently. And then the same with like even, having to go pee. I used to call it emergent pee instead of emergency, because I just all of a sudden it was like I have to go and it's like immediate. And does this not happen to everyone else? It's not like I can wait till the next Tim Hortons. I have to pull over now. And so again, it just really highlights that lack of knowing what's going on in your nervous system and your signals. And I really think that this also could be a key factor for individuals with volume issues that they just might not be aware of.
Absolutely. And actually with binge eating clients, when you unpick it, because you can have both high and low interoception in the same person. So I've seen that too. And that's where I think it gets a bit confusing until you actually see the client. So I would say, just be curious when you're talking to people, but particularly with binge eating disorder and disassociation, I've seen that as a coping strategy, the disassociation as overriding hunger signals, overriding pain. That's a thing that a lot of people do. And that itself can lead to that even further disconnection. So you can just effectively ignore it at the same time. But then when you're hungry, your physiology just held demands and it will make you obsess over something until you actually have it. So thoughts will become really intrusive. So yeah, a lot of work we do is reconnecting that interoceptive awareness, but especially with trauma and particularly with eating, that eating disorder arena, where there almost always are some ACEs, are some level of trauma. It's doing it really slowly. And there's lots of relapsing at times. So we just want to mitigate the relapse because it does affect their confidence, their self-esteem, their well-being.
I'm wondering if you have any thoughts on whether the sensory processing also affects body image, dysmorphia, the way that we feel in our bodies. I certainly know some clients see themselves and feel themselves like certain, like pair of pants that might be a little bit too tight, make them feel a certain size. If any of that you think is correlated at all.
Yeah, definitely. It was previously more associated with autism, their sensory overload is one of the diagnostic criteria. But I am seeing a lot of ADHD, whether they're the ADHD, which I think a lot of people who get missed in childhood, that kind of lost generation, a lot of them are finding they're the overlap with the autism ADHD. There are a lot of sensory issues. One of the things I was talking to another client recently was change. So she could sense her body changing, and it could be clothing. And she, they're not logical, eating disorders are not logical. So she said, I looked horrendous before. So she's in a stage of recovery where not consuming every thought, but she was just sharing, I can feel my clothes are tighter and she's struggling to adapt to change. So it's kind of, it was really difficult for her to sustain her eating. She knew it was good for her. Mentally, she was feeling better, but it was that sensory aspect of her clothing being tighter that she just couldn't deal with. And she was attached to her clothes. She didn't, it's not like, we'll just buy a new sweater. That's just not how it works. So yeah, there's a lot of sensory elements. And with sensory processing, the analogy I always use to talk to my clients about is the mixing desk analogy, and that's where, we might not always relate to what our patients like, but everyone has a completely unique sensory profile. There's no right or wrong profile. It's just their preference. And, a lot of people, some people like novelty, with ADHD as we typically do, but then other people have these safe foods and same foods. So that's when we do a lot of work with ARFID, we're looking at the characteristics of what are those foods that you've chosen and not judging them, but based on their nutritional value always. It's kind of saying, what are the characteristics that you like about them? What's the sensory aspect of them? And just really understanding what it is that makes it safe. And I think that's really getting to know someone's kind of profile and what is going to make them feel good, what's going to be a terrible idea, no matter how healthy it is, it's just going to do more harm. So there's elements of that. A question I always like is if you go to a buffet, like eat all you want. Do you pick the same thing? Because a lot of people will. Or do you like a bit of everything? So you get the people that sit in that, I want to try a bit of everything, just all a novelty. And you get other people who pile their plates of everything the same. And that's always an interesting kind of peek into how their brain works. But yeah, I think with the sensory profile element of it, there's a lot of overlap with interoception, particularly environmental. So a lot of us are sensory to, it's just a lack of filter. We can't filter out a lot of input. So we'll get oversaturated very quickly. People with ADHD, I always think of it as not attention deficit, but we just notice absolutely everything about the environment. So it makes it really hard to focus on my conversation with, a friend when there's everything going on around me. So I can hear other people's conversations. Sometimes you get conversation FOMO because something really interesting is going on in the other corner of the room. So we're absorbing all of this. And a lot of that sensory information can also impact our hunger levels, whether we're able to eat, how safe we feel. So, a lot of people can't eat, particularly children I work with. They can't eat with other people around them. They have to do it on their own. Whereas you get other people, eating mindfully, which we're told is a really good thing, can actually be really overwhelming for them because they're just picking up on everything around them. Even if it's a quiet room, it's just overstimulating. So they have to have aids like a weighted blanket or a screen, which we're told that's really bad. But actually, someone with, who struggles, if I go out to noisy canteen, I can only eat if I look at the phone, and I might not even be doing anything. I might just be whizzing up and down a screen or, playing a game, but it will occupy that part of my brain that gets overloaded. So it's really focusing your attention on one thing so I can actually concentrate on eating. Otherwise, the alternative is I have no appetite and I won't eat and I just run on adrenaline, and that will have consequences. So yeah, it really reframes things like mindful eating and, just no screens.
This is so helpful for me because this is like just having this conversation right now is like there's particular clients that I work with that is like, this now makes so much sense about the mindful eating struggle. And I do. And certainly somebody, and I could certainly relate to like the overwhelm. I've also been on dates and I'm listening to like 15 other conversations and I have no idea, what's actually happening. And you're like, what's going on? I'm supposed to be really present. I'm supposed to be engaged and it just really, it's why I prefer to like go for a walk outside with somebody if I was really trying to get to know them, that those, just being able to be really mindful about what environment is best for you in order to either connect with people, to eat with people, like these kind of skills are going to be, I think, very, very helpful and help people have compassion for themselves as to why when they try these interventions, they don't always work. And it's just because they're actually not the best fit for them.
That's exactly right. And I think it's just being playful, because I think when we work with this sort of thing, it's also fun because you're finding out what you actually like and you're not pathologizing or infantilizing choices. I think when you get adults and you go, do you want to eat the chicken nuggets shaped in a dinosaur shape? And they go, yes, I'd love to. Or the ice cream that with the sprinkles. We just want to know what they like. So I do a kind of intuitive eating exercise with quite a lot of my clients, and they're just trying to connect to, the hunger levels. They're checking in quite regularly because a lot of us won't unless we have an alarm go off or someone tells us to do it. But they'll get to eat whatever they want. So there's no rules of you should eat, kind of balance your blood sugars. For the first couple of weeks of the experiment, it is just, what does your brain say it wants? And then when you eat it, if you're going to eat it, just enjoy it and notice what you like about it. And a lot of people have come back saying, oh, I don't actually like that anymore. It's like I tasted it and it was slimy. I had someone obsessed with, do you know what a fry up is in England? It's a English breakfast. It's just a really greasy, everything's fried, but it's quite good hangover food or comfort food. So she was kind of obsessed with fry-ups and she'd eat them all the time. I was like, inherently, it's not that unhealthy. For her, she was like, this is not good for my life because I don't really want to. It was making her feel a bit ill. So she had to eat it kind of presently and just engage with it and say, right, what do I like? And she's like, there's nothing I like about it. It just reminds me of something from my childhood. So it's like, well, do you still feel like you need to or you want to? But it was a really good experiment in what people actually like when they engage with what the characteristics are. Sometimes it's a cognitive thing. It's just it's not what their body actually wants.
Oh my gosh, I love this so much. I just love it so much. I love learning. I mean, like I'm learning things too. And yeah, so I just appreciate it. So in that vein of learning things from you, and I know we're running out of time, certainly, but I'm wondering, in your experience, what are the most effective treatment approaches, right, for addressing those co-occurring things that are happening, be it ADHD and addiction, ADHD and eating disorder? Like, what's the best approach here?
It's definitely integrative, but I would say the caveat is even integrative practice. It depends on all the pieces that come together because everyone has to be singing from the same hymn book. So the way we work with it is it's neurodivergent affirming care. So the labels are there, but we don't really treat people according to the labels. We look at the person, how they're wired up. We look at them as completely unique mixing death. And we ask them, what is it that you want? Because often people don't ask. We just assume they don't want their eating disorder or they don't want to do that. And sometimes it's like, I don't mind a little binge every now and again. But for some people, they're like, I absolutely hate it, every part of it. I hate myself when I'm doing it. So we just kind of want to know, what are your goals? And you can see what can come up is a lot of internalized ableism, particularly the ones that have done a lot of research on health and nutrition. They think they should be eating a certain way. So even the goal setting is quite different. We're very integrative. So I work with psychology practitioners, occupational therapists, some of stuff like interoception. A lot of people don't take, in our healthcare frameworks, no one really does it. So psychology previously were like, well, that's not our area. And the nutrition side was like, that's not our area. So we just fall into this middle bit where all the problems were happening. So, we kind of work with it now. We do sensory profiles, and it doesn't have to be an official, you get a profile, because to some people that's not the label. We're just trying to find accommodations, the right settings, optimum settings where they can eat peacefully. The type of, if it is with a screen, so you get lots of kids that sit on the sofa or in their bed because that's the only place that their nervous system's calm enough to ingest food. So a lot of it is going back to basic. It's frighteningly basic, but then those modalities, if they're neurodivergent affirming, they do work. They do help the person. That's ultimately the goal. So integrative, holistic. It does have to factor in a lot of the social community side, which probably have no time to touch on that because it's a huge area. But how a lot of issues like substance use and addictions, it can come from their interaction with society, kind of the roles and the systemic oppression, all of those massive topics, to even think of, right, someone's overweight. Well, by what metric? And then if you're using things like the BMI, which everyone's now cancelled, but hasn't filtered down to some healthcare providers, your goals and your barriers to kind of appropriate care can be restricted by things like that. So we're really, I think everyone has to be on that same page with that neurodivergent affirming approach. And then a lot of tools that we can use some behavioural strategies. So I do work with practitioners that do use some standardised tools, but they'll adapt them to be more neurodivergent affirming. So it's just kind of incorporating that person's way of sensory or emotional regulation that works for them. And it might look odd, it might not sit right with some people, but it's just being more open-minded. So that's the best approach at the moment for me, because I think there isn't a framework that really covers all of this at the moment. Definitely not an integrative one. And when patients do go around to a lot of different practitioners, particularly multidisciplinary, that aren't really on board with all of this, it's really demoralizing for them because they're told one thing by one person, or you get lots of different people doing different protocols at the same time. And I think that's really overwhelming for someone who we actually need to simplify things and help them with the executive functioning. And I've seen a lot of kind of problems, people struggling with that. So sorry if that it wasn't a straightforward answer, but.
But I don't think there is a straightforward answer, right? I mean, it sounds so much like it makes, like, we know that food can regulate our nervous system, right? It can take us from sympathetic and put us in parasympathetic. So the fact that individuals with ADHD, use food to soothe, to regulate, makes a lot of sense. And also, that they may use substances to quiet the noise of the outside world. And I just wondered before, we switched to our signature question, if you could speak a bit about masking, and some of these coping mechanisms we develop in order to cope in the world that then may explain why we have gone to food, why we have gone to substances to just help, us maybe even feel safe.
Yeah, absolutely. And safety is the key. So when I become sensory overloaded, and it could be for my choice, I've gone to a meeting, I know there's going to be loads of people there, it's somewhere I want to be. That sensory overload, rejection sensitive, all of those things start to come up when I'm fatigued and when I'm stressed in a sensory way. And substances like alcohol do numb those things. So they're very good, they're a way of masking, if you like, because they kind of lower your inhibitions, they make you a bit more sociable, and they do kind of numb that sensory experience. So naturally, I became quite dependent on using that socially. And then you become associated with that personality, like, oh, you're really fun to be around because you're just a much more chilled out version of yourself. But then that's not a really good, you think, well, if I stop drinking and I go completely sober to this thing, I'm going to be unrecognizable. So you get trapped in that cycle quite a lot. So the alternative is staying at home and not doing anything. So it becomes this really difficult thing to break because it does help with the sensory overload. So it's hard to have the right answer for this because there's lots of other emotional regulation tools that individually will work for people and loads of other kind of treatment strategies and interventions that we can use. So it's kind of exploring those things. But yeah, effectively masking is hiding your true self. It can be beneficial, as in, it kind of reduces stigma and it can give you more opportunities. And sometimes it's necessary from a survival perspective, but it does have kind of very negative mental health consequences later on down the line. So this does set you up for those co-occurring issues. So eating disorders is one of them, but self-harm and, kind of further substance misuse. So it's a very vicious cycle of using it as a coping strategy for sensory overload, but then it can lead to kind of other issues.
Yeah, because it's exhausting as well to do if you're doing it all day, like every day, and like you're not even really capturing it. I think so many people don't even necessarily know they're doing it. It's like, I know I can flip into it in a hot second just because, again, it's like you said, it feels safe, right? So you just kind of present a certain way and you may not even be fully present as to your awareness that you're in that mode until like you leave the situation and you're like, oh, like that was exhausting.
Oh, yeah, absolutely. Yeah, masking is one of the most exhausting things you can do. And I think before I got diagnosed, I wasn't even aware I was doing it. All I knew was I was just tired and I would have outbursts. And you can kind of see why it gets, like autism in particular. I think the most common misdiagnosis is borderline personality. But I could actually see why, because I would come home and I'd be this really pleasant, sociable person, and I'd just cry and want to self-harm and have a complete meltdown. And whoever was around me, partners, housemates, my parents, they'd probably think, what is going on? They were like, something's seriously not right, but they didn't know it was an autistic meltdown or an ADHD meltdown. So it has such a big impact on when you're hiding everything and then you have to let it all out. There's a lot of internalized masking. So sometimes it's not even safe to be yourself at home. And I've had a few clients, talk about that. And there is even higher rates of self-harm, suicidality, and also internalized symptoms. So you get things like fibromyalgia, which is a whole topic I love because I worked with that field, but chronic pain, IBS, really complex illness comes up in that situation when you can't even be yourself at home, when you're masking at home and outside. So huge impact.
Definitely. I mean, and I think all of this to say it's complex, right? I think the world demands we're put in boxes. It's black and white. It's good. It's evil. It's healthy. It's not healthy. It's whatever. It's clean. It's dirty. We work in these opposites that everything has to fit cleanly or nicely somewhere. And when it doesn't, we struggle to figure it out. And I'm a person who loves to live and play in the gray. And I think you are too, Claire. And I think Clarissa is too. And certainly we work really hard with our clients to try to experience that as well, to just give themselves more grace and self-compassion, because you're right. Like sometimes they're going to providers who don't talk to one another, who don't, practice neurodivergent affirming care, trauma-informed care, any of those things. And so it can be really difficult to navigate. So I just appreciate that you are fighting the good fight, that you're out there working hard to try to change the tides.
And I'm grateful for you guys too, because it's exactly that. There's people who are frightened of the grey area and the complexity, and we kind of don't run from it and we turn towards it. And I think that's kind of what I was looking for. And perhaps you guys were when we were struggling. You wanted someone to not just put you in a box and like pack you off to, you're not my problem anymore. You kind of want someone with a bit of curiosity as to why things are happening.
Definitely, definitely. So before you go, where can our listeners find you?
Good question. A bit of a recluse. So at the moment, I don't even know my Instagram handle. It's Nutrition for Neurodiversity. And I can send you kind of things to put in the show notes. Yeah, I'm not practicing, I'm not taking on clients at the moment, but I work with quite a few neurodivergent affirming, functional medicine practitioners. So the company is the Creative Well, but there's dashes in between all of the words. So I'll send you a link to that. And I'm working on, my website should be out in a few months. I'm trying to be realistic time frame wise, but it will just have free resources for advocacy and kind of all of this stuff, because I just wanted a place to put all of this information out there for the people that might not have access to that sort of care. So keep an eye out for that. But for the moment, the Instagram is where I'm sort of most active and people can kind of send me a message.
Definitely. And we'll make sure to update the show notes too once the website is live so people can have access to that. So before you go, we have a signature question. We like to tailor it to each guest. So if you could tell a younger version of yourself something about ADHD or neurodiversity, what would it be?
I always struggle with this question because I kind of think, what would I have done with that? And I wonder what I would have done with that. I guess it would be, don't worry. I think I live my life as such a worried, kind of self-conscious person. There's actually lots of people like you out there. You're not a failing human being. You're just wired up differently. And I kind of wish I had a whole list of the strengths and I could balance it out with the deficits that people kept reminding me of. So that would have been just a reminder that everything would turn out okay.
Okay, I have a quick question about that. On your website that you're building, will you have a list of the strengths?
Absolutely. And I will put them out. I actually need to do that for all of all of my diagnoses. Absolutely. Yes.
Yeah. And you did it in your presentation that I saw with you. And maybe we'll include that in the show notes too, just so that people can see. I think we just ran out of time today and we might just have to have you back and talk more. Because again, we touched on the eating. We didn't touch a ton on the addiction and that framework. And so, yeah, we would love to have you back to talk more.
Amazing. Yeah. No, that'd be fantastic.
Well, thank you so much.
Oh, thank you guys.
Thanks for joining us this week on Food Junkies, Recovery from Food Addiction. Make sure to join our Facebook group, Sugar Free for Life support group, I'm Sweet Enough. You can subscribe to our show in iTunes or Stitchers. That way you'll never miss an episode. While you're at it, if you found value in this show, we'd appreciate a rating on iTunes. Or if you'd simply tell a friend about the show, that would help us out too. Don't forget to pick up your copy of Dr. Tarman's book, Food Junkies, which is available on Amazon. If you have any additional questions, both Molly and Clarissa are food addiction professionals and work one-on-one with clients. You can find their websites and email addresses in the show notes. Be sure to tune in every Friday when our new episodes drop. As Vera loves to say, the power is ours.